Okay, let's go.
You know, there is this pervasive myth in medicine that the hard part is the diagnosis.
Oh, absolutely.
Like once you finally get the label, whether it's hypertension or major depressive disorder, the treatment is supposed to be the easy part.
Right, you just follow the playbook.
Exactly. You follow the algorithm, you write the script, and the patient gets better.
If only it were actually that simple.
Right.
Because we know that in mental health specifically, that algorithm is often more of a flowchart. And it's a flowchart with a dozen different exits.
Yeah, and that's exactly what we're digging into today for this deep dive. I'm your host, by the way.
And I'm your resident clinical expert. Glad to be here.
So today, for everyone listening, we are looking at a stack of clinical guidelines. We've got the Royal College of Psychiatrists in the UK, the Australian Prescriber, and the BC guidelines here in North America.
It's a really solid global mix of sources.
It is, and they're all focused on one incredibly high-stakes moment.
Which is when the antidepressant just stops working.
Or, worse when it never worked to begin with.
Yeah, that's the classic treatment resistance pivot point.
Right.
And what's fascinating about these documents is that they move us away from the emotional frustration of that moment.
Which is huge for the patient, obviously.
Absolutely. But the guidelines move us into the actual pharmacologic mechanics of what comes next. It's a guide on tapering switching antidepressants. It's not about guessing anymore.
It's about navigating a very specific decision tree.
Exactly. And our mission today is to look at the three main factors that dictate how a doctor actually proceeds in that moment.
And according to the sources, those are patient preference, the specific profile of the medication, and how the patient is currently responding.
Or how they're suffering from side effects. That's a huge piece of the puzzle.
Right. And looking at the material, the very first thing that jumped out at me was this concept of diagnostic clarification.
Oh, that's such a critical concept.
Because it's so easy to view a failed medication as just a failure, full stop.
Mm.
But these guidelines suggest that the failure itself is actually data.
Precisely. If you have a patient who is non-responsive to a standard SSRI,
Right.
and then they're non-responsive to an SNRI, the clinician really has to stop and ask, is this actually unipolar depression?
Could be bipolarity.
Exactly. Or could it be a thyroid issue? The lack of response literally forces you to reevaluate the underlying biology.
It essentially turns the medication trial into a diagnostic tool.
It does.
But let's assume for a second that the diagnosis is correct.
Okay.
But the drug just isn't hitting the mark. We are standing at the first major fork in the road that's presented in the text.
The big decision.
The decision to switch entirely or to add a second medication, which they call augmenting.
The classic clinical dilemma. Do we clean the slate or do we double down?
And I think for a lot of people listening, augmentation feels a bit counterintuitive.
How so?
Well, if the first drug isn't working, why keep a failure in the system? Why not just toss it?
That makes sense from a lay perspective, sure. But the guidelines make a pretty compelling case for what they call the partial response.
Okay, let's unpack that.
That's the key variable here. If a patient has seen some benefit, maybe their sleep is a bit better, or their energy is up 20%, but their mood is still flat.
Right, they aren't fully better.
But you don't necessarily want to zero out the progress they have made.
You've gained some ground. So augmenting allows you to hold that territory while bringing in reinforcements.
Exactly. You preserve that partial remission. And crucially, you avoid the volatility of a washout.
The withdrawal phase.
Right. When you stop a drug, you invite withdrawal effects and the potential return of baseline symptoms. Augmentation basically bypasses that instability because the baseline drug stays on board the whole time.
However, the guidelines are very upfront about the downside of that stability. We have to talk about the polypharmacy burden here.
Yes, the elephant in the room.
Because it's not just about the physical pill count. The source material highlights how augmenting exponentially increases the risk of adverse effects.
And drug interactions. It's just simple math.
Right.
You introduce a second agent, maybe an antipsychotic or a mood stabilizer, and you are now managing two entirely different metabolic profiles.
You're doubling the workload on the liver.
Doubling the receptor activity. It gets complicated fast.
And let's be real about the adherence aspect too. We know from the data that as soon as a regimen becomes take pill A with breakfast and pill B at dinner, compliance just drops off a cliff.
Oh, absolutely. Non-adherence is basically the silent killer of augmentation strategies.
Because it's just too much to remember.
If the patient gets overwhelmed by the complexity, they might stop taking both of them, and then you're in a much worse position than where you started.
Which naturally leads us to the other path on this decision tree.
The switch.
Right, the clean slate approach.
This is the strategy you use when there is no partial response worth saving, or, when the side effects of the first drug are just intolerable for the patient.
You want to move back to a monotherapy.
Right.
One drug, one distinct mechanism.
Exactly. It solves the polypharmacy issue entirely and makes adherence so much easier for the patient.
Just one pill a day.
But the trade-off, and this is outlined very clearly in both the Australian and UK guidelines, is what we can call the gap.
The therapeutic vacuum.
Right. You have to get the old drug out of the system, and you have to get the new drug in.
And because of the titration schedules.
Because you can't just hit the maximum dose on day one safely.
Right. So there is inevitably a period where the patient is going to be under-medicated.
Yes. And that gap is where things get really tricky.
And honestly, reading through the sources, this is where the art of the science really comes in. The guidelines actually detail 4 distinct ways to execute a switch.
4 very different mechanical strategies.
Yeah. And I realized this is where the clinician really earns their paycheck. It's not just a simple matter of stop taking this one and start taking that one.
Far from it. The choice of which strategy to use depends entirely on the half-life of the specific drugs and the fragility of the patient in front of you.
Okay, let's break these down for the listener. Strategy number 1. The direct switch.
This is definitely the most aggressive approach.
But just ripping off the Band-Aid.
Basically, you stop drug A completely on Monday, and you start drug B on Tuesday at the equivalent dose.
Which sounds incredibly risky to me. But the guidelines suggest this is actually preferred in some very specific scenarios.
Yes, specifically when you're switching between drugs in the exact same class.
Like going from one SSRI to another SSRI.
Exactly. Because the mechanism of action is so similar,
Yeah.
the brain doesn't experience as much of a shock. The receptors are still getting hit with serotonin, just by a slightly different molecule.
So it's fast, it's clean, and it really minimizes that dangerous gap we were just talking about.
Right. But if the drugs are chemically distinct, or if the patient has a known history of sensitivity, the direct switch is completely off the table.
You can't risk it.
No. And that's when we move to strategy number 2. Taper and switch immediately.
Which seems to be the more conservative standard.
It is. You slowly lower the dose of drug A until it's at 0, and then you immediately start drug B.
The nuance here really seems to be about distinguishing the symptoms.
How so?
Well, if you do a hard direct switch and the patient suddenly feels terrible, you don't really know what's happening. Is it withdrawal from the first drug, or is it a bad reaction to the new drug?
Spot on. The taper separates those variables. It allows the clinician to monitor the discontinuation of that first drug in isolation before introducing a brand new chemical variable.
It's a much softer landing.
It's safer, but the downside is that it extends the timeline of the transition.
Right. It takes patience. Which brings us to the third strategy, and this is the one that fascinated me the most, cross-tapering.
Oh, the relay race approach.
That's a perfect way to describe it. You're tapering down the old drug while simultaneously jolting up the dose of the new one.
They overlap.
Yeah, and it seems like the most elegant solution to the gap problem because you never actually leave the patient unmedicated.
It is an elegant concept, but it's pharmacologically very noisy. Yeah, because for that overlap period, which is usually a week or 2, sometimes longer, you are technically practicing polypharmacy again.
Ah, I see.
You have 2 active drugs in the brain competing for the exact same enzymes and receptors.
So you need a patient who is reliable enough to manage a fairly complex, changing dosing schedule at home.
And you need a clinician who is highly vigilant about interactions. You have to constantly watch for things like serotonin syndrome or other additive side effects.
Because if you have 2 drugs both boosting serotonin at the same time, you can easily overshoot the mark.
Exactly. But for a patient who simply cannot afford a relapse, say, someone who becomes acutely suicidal or completely non-functional without medication, the cross-taper is often the necessary risk to take.
You have to weigh the dangers.
Always.
Which perfectly sets up the fourth strategy.
Yeah.
And this is the one with the flashing red warning lights around it in the text.
Yes. Taper and switch after a washout.
This is where we step away from clinical preference and move into strict biological necessity.
The rules change here.
Big time. The guidelines are absolutely adamant about this strategy, specifically regarding MAOIs,
Monoamine oxidase inhibitors.
Right. The source material explicitly states that this isn't a recommendation. It's a hard rule. You taper off the first drug and then you just wait.
You wait for 5 half-lives of the drug to pass.
Which the text says is usually a 7 to 14-day washout period of taking absolutely nothing.
And we really have to explain why that is, because to a lot of people, it sounds almost cruel to leave a severely depressed patient with 0 medication for up to 2 weeks.
It does sound brutal.
But it comes down to the enzyme. MAOIs work by irreversibly inhibiting the enzyme that naturally breaks down neurotransmitters in the brain.
Irreversibly, meaning the enzyme is just permanently destroyed.
Yes, that specific enzyme molecule is gone. So your body actually has to synthesize brand new ones from scratch, and that biological process takes time.
So if you introduce a new antidepressant, while those enzymes are still knocked out,
you flood the brain with neurotransmitters, specifically serotonin and norepinephrine, that the brain currently has no way to break down or clear out.
wow, and that leads to a hypertensive crisis.
Or serotonin syndrome, both of which can be completely fatal.
So that washout period isn't just a break to clear the system, it's a mandatory safety corridor.
Exactly. You are literally waiting for the body to regenerate its enzymatic function before you can safely introduce a new chemical agent.
It's a very stark reminder of the incredible potency we're dealing with here. We casually call them antidepressants, but these aren't just gentle mood boosters. They are profound metabolic disruptors.
Absolutely they are. And that washout period is arguably the most vulnerable time for any patient.
Because they have no safety net.
Right. They are entirely unmedicated. They are potentially going through physical withdrawal, and they are still dealing with their original untreated depression.
That has to require incredibly close monitoring.
It does. Sometimes it even requires inpatient care just to keep them safe during that 2-week window.
Speaking of that vulnerability, that brings us to a major theme that shadows all of these guidelines.
The withdrawal factor.
Right, what the sources formally call antidepressant discontinuation syndrome.
This is the massive confounding variable in all 4 of the switching strategies we just talked about.
And it was listed as one of the key disadvantages in that initial switching versus adding table, too.
Because it's a nearly universal risk when you stop these medications.
And reading the symptoms of withdrawal, the anxiety, the insomnia, irritability, the mood instability, it strikes me that it looks an awful lot like the depression itself coming back.
That is precisely what we call the relapse trap.
The relapse trap.
Yeah. A patient stops taking drug A, they feel absolutely terrible 3 days later, and their immediate thought is, oh no, my depression is back, I can't live without this pill.
But 3 days is really fast for a true depressive relapse, isn't it?
Exactly. Physiologically, 3 days is usually way too soon for a full depressive episode to reemerge. It's much more likely that the brain is just reacting to the sudden chemical vacuum.
It's physical withdrawal, not a psychological relapse.
Right. And if the clinician makes the mistake of confusing withdrawal for a relapse, they might make the wrong move entirely.
They might restart the old drug, thinking it was essential.
When in reality, they just needed to manage the taper a bit slower. That's why the UK guidelines from the Royal College of Psychiatrists specifically emphasize this point.
The need to distinguish between the two.
Yes, you have to monitor if it's the reemergence of symptoms, which typically happens gradually over weeks, or if it's withdrawal, which hits very quickly after a dose reduction.
It's really interesting to see the global consensus on this, by the way.
It really is unified.
Yeah, whether you're reading the BC guidelines from Canada or SwitchRx or the Australian prescriber, the core physiology just dictates the protocol across the board.
Because the geography changes,
Yeah.
but the human biology doesn't.
Right.
The consensus across all these continents is clear. Safety first, customize the switching strategy to the specific patient, and monitor the transition like a hawk.
So as we wrap this up, when we step back and look at this entire decision tree we've explored, balancing the polypharmacy risks of augmenting against the withdrawal risks of switching.
And then navigating those 4 different paths of making the switch.
Right. It really highlights that the era of trial and error in mental health is getting so much more sophisticated.
It is. We are finally moving away from that old mentality of just throwing pills at the wall to see what sticks.
And moving toward what?
Toward a much more mechanistic understanding of exactly why a drug fails and how to safely and strategically navigate the change.
And for anyone listening who is navigating this themselves, the big takeaway from these sources is that knowledge really is power here.
Absolutely. Understanding these mechanics helps you advocate for the strategy that actually fits your life.
Right, like asking yourself, can you safely handle a 2-week washout period? Or are you organized enough to manage a complex cross-taper with multiple pills.
You have to know your own limits.
It's a complex map, but obviously a very necessary one.
But, looking at all this complexity leaves me with a final kind of provocative thought about where this is all heading.
Oh, what's that?
Well, if we currently have 4 entirely different ways just to switch a medication, and we need dense guidelines from 3 different continents to manage it safely, it just shows how incredibly individualized mental health treatment is.
Right.
So the question is, are we moving toward a future where we don't have to use this flowchart at all?
What do you mean?
Imagine if we could actually predict which switch strategy works best for a patient's specific biology right from the start. Rather than relying on trial and error, we rely on pharmacogenomics to say, this specific brain needs a cross taper, but this other brain needs a direct switch.
Wow. Predicting the switch based on their exact metabolic profile? That would change everything.
It's the next frontier.
Well, that is definitely something for all of us to mull over. We will leave the deep dive right there for today. Thank you for navigating the chemistry with us.
Always a pleasure.